A routine induction can turn chaotic in seconds. The alarms trigger in rapid succession. Severe tachycardia, end-tidal CO2 rapidly climbing off the monitor. Severe muscle rigidity locks the patient's jaw shut. General anesthesia is a medically induced coma, a deeply controlled toxicological state that forcefully suppresses fundamental homeostatic mechanisms. Surviving this environment means deconstructing precise pharmacology and anatomy to predict failures before they manifest. When physiology fails, survival relies entirely on the anesthesiologist bypassing slow cognitive processing in favor of precompiled, aggressive mechanistic rescue algorithms. Look at this 3D model of the human airway. To successfully intubate, we have to precisely align the oral, pharyngeal, and laryngeal axes into a single direct line of sight. We force this geometric alignment mechanically with a head tilt and chin lift maneuver.
The view shifts here to the oral cavity, categorized by the Malampati classification. It grades the visible space relative to the base of the tongue, from complete visualization of the soft palate and tonsillar pillars in Class 1 to seeing strictly the hard palate in Class 4. Improper positioning, like keeping the patient supine or allowing them to speak during the test, artificially alters the grading and masks a difficult airway. Switching to a profile view, we apply the 3-3-2 rule to calculate spatial geometry. We need 3 fingers of interincisor distance for adequate mouth opening, 3 fingers of thyromental distance to confirm the submandibulous space can physically accommodate a displaced tongue, and 2 fingers of thyrohyoid distance to locate the larynx. These individual anatomical tests are consolidated into the Lemon criteria. Look externally, evaluate the 3-3-2 rule, Malampati score, obstruction, and neck mobility. Systemic anatomy matters just as much. This silhouette demonstrates how dense adipose tissue in severe obesity physically compresses the diaphragm and lungs. This compression causes a drastic reduction in functional residual capacity, the oxygen reservoir in the lungs, leading to rapid oxygen desaturation the moment a patient stops breathing. These limitations feed directly into the ASA physical status classification system to quantify surgical morbidity risk. A morbidly obese patient automatically triggers an ASA reclassification due to the severity of their functional limitation. By combining multidimensional airway scoring with systemic risk stratification, the anesthesiologist calculates the exact time window they have to secure the tube before the patient suffers apneic desaturation. Preparing the patient's physiology begins well before the operation. The 2023 ASA fasting guidelines strictly maintain a 6-hour fast for solid foods, but actively encourage liberalized clear fluid intake up until 2 hours before surgery. Surgical trauma induces insulin resistance, blocking glucose uptake. Preoperative carbohydrate loading attenuates this, preserving muscle mass. However, a stomach cross-section reveals another danger. GLP-1 agonists drastically delay gastric emptying. This delayed motility severely increases the risk of silent regurgitation and pulmonary aspiration. Other metabolic medications require strict preoperative cessation. SGLT2 inhibitors are held for up to 4 days prior to surgery. Fasting combined with surgical stress forces the body into lipid metabolism, producing massive ketones and triggering severe euglycemic diabetic ketoacidosis. Cardiovascular drugs present a dual risk. ACE inhibitors taken solely for isolated hypertension are withheld to prevent intraoperative vasoplegia and severe hypotension. Beta blockers, conversely, must be continued. Chronic therapy upregulates beta-adrenergic receptors, and abrupt withdrawal exposes these highly sensitive receptors to surgical catecholamines, precipitating severe rebound tachycardia and myocardial ischemia. Modulating chronic medications is a calculated gamble. You balance the probability of baseline disease exacerbation against the threat of intraoperative drug interactions. This dose-response chart defines general anesthesia. Potency shifts the curve along the x-axis, while efficacy is the peak on the y-axis. For inhaled agents, potency is the minimum alveolar concentration. As the vaporizer turns up, we hit the threshold preventing movement to surgical incision. Intravenous induction agents are selected based on strict hemodynamic profiles. Propofol causes extensive vasodilation and decreased myocardial contractility, triggering cardiovascular collapse in patients with hemorrhagic shock. Ketamine is used instead. It provokes endogenous catecholamine release, stimulating the cardiovascular system and preserving blood pressure. Etomidate offers unparalleled cardiovascular stability, making it the agent of choice for severe coronary artery disease. However, it reversibly inhibits the mitochondrial 11-beta hydroxylase enzyme, impairing cortisol synthesis for up to 24 hours. Inside the central nervous system, volatile anesthetics uniquely uncouple cerebral flow and metabolism. They suppress oxygen metabolism, but directly vasodilate cerebral vessels, resulting in a net increase in cerebral blood flow. This drives up intracranial pressure, creating a highly detrimental state for neurosurgical patients with poor compliance. There is no universal anesthetic. Induction agent selection is entirely dictated by exactly which organ system vulnerability a patient's hemodynamics cannot tolerate. To induce flaccid paralysis, we target nicotinic receptors on the motor end plate. Succinylcholine mimics acetylcholine, forcing the ion channel open to cause sustained depolarization. Conversely, non-depolarizing agents like rocuronium act as competitive antagonists. They occupy the subunits, physically preventing the channel from opening. Severe thermal burns or spinal cord injuries trigger a rapid, massive upregulation of extrajunctional fetal-type receptors across the muscle membrane. Administering succinylcholine holds these abnormal channels open, allowing a massive potassium efflux that instantly triggers lethal hyperkalemic cardiac arrest. Myasthenia gravis presents the exact opposite pathology. Circulating autoantibodies destroy the postsynaptic receptors. With fewer targets available, patients are resistant to depolarizing agents like succinylcholine. Yet they become exquisitely sensitive to competitive antagonists like rocuronium, leading to prolonged paralysis. For critically ill patients with end-stage liver or renal failure, we use benzyl isoquinyllium compounds like cisatracurium. They undergo Hofmann elimination, a spontaneous chemical degradation directly in the plasma, dependent solely on physiological pH and body temperature, bypassing the liver and kidneys. Subjective evaluation of reversal is notoriously inaccurate. Up to 80% of patients capable of performing a 5-second head lift still possess significant residual paralysis. Safe extubation demands a quantitative train-of-4 ratio strictly greater than 0.9 to prevent postoperative hypoxic respiratory failure. This nerve cross-section illustrates the sequential blockade of local anesthetics. Thinly myelinated sympathetic B fibers are blocked first, causing vasodilation. Next are sensory A delta fibers, then large motor A alpha fibers. If a high-volume injection absorbs into capillary beds, it triggers local anesthetic systemic toxicity, or LAST. LAST follows a distinct biphasic clinical progression. It initiates with selective cortical excitation, manifesting as perioral numbness, metallic taste, and violent tonic-clonic seizures. As the plasma concentration climbs, this devolves into global central nervous system depression, respiratory apnea, and severe bradycardia. The definitive rescue therapy is intravenous lipid emulsion, functioning as a lipid sink. This massive intravascular lipid compartment physically extracts and sequesters lipophilic anesthetic molecules away from vulnerable tissues in the brain and myocardium, while providing a concentrated energy substrate to the failing heart. Concurrent advanced cardiac life support must be heavily modified. Standard epinephrine doses severely impair lipid rescue therapy. You must aggressively scale down to fractional microdoses. Propofol is strictly avoided for seizure control, as it exacerbates the underlying cardiovascular depression. Surviving a LAST event requires recognizing the predictable prodromal seizure phase and deploying the lipid sink before the cardiotoxic anesthetic binds permanently to the myocardium. Spinal anesthesia accesses the subarachnoid space. A cutting quink needle severs dural fibers, creating a rent that leaks cerebrospinal fluid. This causes a severe post-dural puncture headache. Conversely, a pencil point Whitaker needle gently separates the fibers, elastically closing upon withdrawal and vastly reducing leakage. Caudal anesthesia is a cornerstone pediatric epidural block, but infant anatomy presents a unique danger. The dural sac terminates much lower, at the S3 to S4 level. This drastically increases the risk of an inadvertent dural puncture, precipitating a life-threatening total spinal block. In shoulder surgery, the traditional interscalene block guaranteed near 100% ipsilateral diaphragmatic paralysis by depositing local anesthetic intimately close to the phrenic nerve. Modern ultrasound-guided motor-sparing blocks strategically target the sensory innervation distally, completely avoiding the cervical nerve roots. Modern block selection trades blunt regional denervation for precise anatomical targeting, completely preserving dynamic pulmonary mechanics in highly compromised patients with severe respiratory disease. The cognitive load during a critical physiological failure is overwhelming. This standardized anesthesia emergency drug tray provides immediate cognitive offloading. Precise spatial orientation and strict color coding directly prevent calculation errors during high-stress events. That houses the precise rapid response agents: epinephrine to rapidly restore vascular tone during severe hypotension, atropine to instantly reverse hemodynamically catastrophic vagal bradycardia, and succinylcholine to break a refractory, life-threatening laryngospasm. This strict standardization ensures the specific molecular antidote is in the provider's hand the second a mechanistic pattern is recognized. Returning to the chaos of our opening induction crisis. The rapidly climbing end-tidal CO2 alongside sudden, isolated masseter muscle rigidity signals a massive hypermetabolic state. The clinical diagnosis is malignant hyperthermia. The emergency algorithm is executed immediately. The triggering halogenated volatile anesthetic is halted. The patient is hyperventilated with maximum fresh gas flows of 100% oxygen to off-gas the residual vapor, and the dedicated malignant hyperthermia cart is brought in. The definitive pharmacological antidote is dantrolene sodium. Administered rapidly via a large-bore IV line, it acts as a direct molecular antagonist. It specifically binds to and blocks the massive calcium release from the defective RYR1 channels, immediately halting the hypermetabolic cascade at the cellular level. Safe anesthesia requires the mastery of physiological deviation, anticipating the anatomical insult, recognizing the pattern of pharmacological failure, and executing the rescue flawlessly.